welcome to Dr. Mackey's Sacramento County EMS July 2022 Policy Updates video. Kevin Mackey, thank you so much for putting this video together. It's very helpful and instructional, and I hope you enjoy and take advantage of the CDs.
Thank you, Hernando, for that introduction. My name is Kevin Mackey. I'm the Medical Director of the Fire Agencies and Dispatch here in Sacramento. This is your July 2022 protocol update. On July 1st of every year, the county turns out new policy changes, and the design of this video is to take the volume of material that will be changing in July and to break it down to some digestible pieces. 62 policies have come before the MAC and OAC for consideration for changes. Of those 62 policies, only 21 of them have either minor or major changes that will impact your work in the field. So we're going to go through each of those 21 policies one at a time. I'm going to call out some of the key changes and remind you of key features of each of those policies. And I hope by the end of this that it'll make this whole process of change that we go through in July a little bit easier. There will be a CE test attached to this that you'll be able to get CE credit for through the county. So let's go ahead and get started. All right, Policy 2060. This is the first of 6 policies in the 2000 section, which is EMS systems. So in 2060, called Hospital Services, the VA Medical Center is the only change to this policy. There are 3 patient types that can go to the Sacramento Veterans Administration's Medical Center. Those patients are veterans who request transport to the VA. It can be a patient under CPR when the VA is the time closest facility, and also patients who have unstable airways when the VA is also the time closest facility. An unstable airway defined as inability to adequately oxygenate or ventilate a patient despite your best efforts. Policy 2085. This policy is do not resuscitate policy. It has some minor changes associated with it. In this policy, there's a section that asks to please attach a photo of the DNR, the POLST, the living will, or the DNR medallion to the EPCR. Simply take a picture of it, make it part of the patient's records. And then there's also the section following that, which reminds you to please transport that documentation with the patient to the hospital for continuity of care, so the hospital understands and knows that patient's wishes as well. Policy 2101, patient-initiated refusal of service. There are a couple of changes here as well. In 2101, patients with a POLST or a physician order for life-sustaining treatment that indicates no transport may decline transport per policy 2085. But also importantly, under policy 2101, there is a new section that is added that calls out unstable vital signs. So if you look under procedure number 4, which requires base hospital consultation with an ALS provider, letter D now lists unstable vitals. Those unstable vitals are a systolic blood pressure less than 90, a resting heart rate greater than 120, or a respiratory rate greater than 20. So if you have a patient that is wishing to refuse service, and you have acquired vital signs, as we should on all of them, and you understand or discover that one or more of these vital signs are abnormal, you must make base hospital contact for that refusal. Next, policy 2200, medical oversight. In this section toward the bottom, there are 4 major sections under the policy: direct medical oversight, standing orders, base hospital orders, and base physician orders. The 2 sections that have added language are base hospital orders and base physician orders. A base hospital order is protocol driven, by the Sacramento County EMS agency policies and can be given, and only can be given, by a certified MICN or by a base hospital physician. Now, base physician orders are orders that can be given by a base hospital physician that must be within the scope of practice of a paramedic, but may not necessarily have a directly applicable policy in Sacramento County agency policies. A good example of this might be the use of bicarb in crush injury. Bicarb is part of the paramedic scope of practice, but there's no specific policy for it. If you find yourself with a patient or a patient's condition that may warrant treatment but doesn't specifically have a policy, that requires a base hospital physician order that can be given by either the base hospital physician or can be given and communicated through an MICN. Next, policy 2524, our friendly policy, extended ambulance patient offload times, or APOT. There's no major changes to this policy, but I did want to point out some very key features that I want to remind everybody about because sometimes they get forgotten. So a couple of those important reminders are called out in the policy. Remember, vital signs are required every 15 minutes. If the patient comes in on a cardiac monitor, they need to stay on that cardiac monitor, please. And you're allowed to continue treatments that you started when you come into the hospital while you're waiting on a wall for a bed. And this policy does allow for minimal diagnostic things that are done by the hospital, but they have to be within the paramedic scope of practice, like obtaining a blood glucose, drawing labs, getting an EKG. But things that are outside the paramedic scope of practice, a hospital is not allowed to do while on an ambulance gurney waiting to offload the patient. If your patient's condition worsens, and that's defined as a change in vital signs, level of alertness, having to continue a treatment or start a new treatment, that does require immediate communication to a hospital staff. Very important that that's communicated. The other things we need to do to communicate are every 20 minutes we want to be checking in with the hospital staff to just check on bed availability. And when you hit the 60-minute mark, please advise your supervisor that you've been waiting for a bed for 60 minutes and so it can be escalated up through the communication chain. Last one in the emergency medical services section is 2525, which is pre-hospital notification. I only added this in there. There's no major changes. Just to remind everyone that the key alerts that we use in this county are stroke, STEMI, trauma, cardiac arrest, sepsis. All right, that finishes our emergency medical services systems policy changes. Let's move into the adult and pediatric changes. Okay, let's move into the new sections for adult and pediatrics. That is the 8,000 series for adults, the 9,000 series for kids. In here, we see some pretty major changes. The decrease in soaring protocol for both adults and kids is being sunsetted. It's going away. Each of those is being replaced by 3 new policies that cover diabetic emergencies, seizures, and suspected overdoses. So you'll see 6 new policies, 3 for adults, 3 for kids. You'll also see a new traumatic arrest policy, and then you'll see some major changes in a couple of the other policies. So let's dive in and see what's changed and what's been added. For the adults, policy 8002, diabetic emergencies. In this policy, and in all of the other policies, there is a constant reminder to keep a broad view. Don't get tunnel visioned in on what you necessarily are convinced is going on with this patient, because honestly, I think in some of these patients, the thing that gets forgot the most is sepsis. But for diabetic emergencies, it does call out very specific criteria. And what you're going to love about this is that I've been asked several times over the last few months is, when are we going to begin to treat hyperglycemia? Well, here it is, and the new policy starting on July 1st of this year. So for adult diabetic emergencies, once you've considered other causes like AEIOU tips, hypoglycemia defined as a GCS less than 14, a blood glucose less than or equal to 60, a history of diabetes, in these patients, EMTs can administer oral glucose, and that is for someone who's completely alert and oriented. So this cannot be someone who cannot tolerate the oral glucose. But for paramedics, the treatments are 10 to 12.5 grams of dextrose IV, and that can be given as either D50 or D10. And if the blood glucose remains
Less than or equal to 60.
there is an ability to give additional doses of 12.5 to 15 grams. And this can be repeated to a total of 50 grams, which is going to be 100 cc's of D50 or 500 cc's of D10. Now, if you don't have an IV, we do carry glucagon, and you can give glucagon. But you have to wait to reassess after 15 minutes before the next treatment can begin. If there's still ongoing issues after those 15 minutes, an IO can be started for sure, if there's no improvement in responsiveness. Now, what about glucometer failure? If your glucometer fails and there is a history of diabetes in the patient that you're aware of, and the GCS is less than 14, it is okay to give that first 10 to 12.5 grams of dextrose or glucagon. All right, let's transition over to hyperglycemia, adult hyperglycemia. In the case that the blood sugar is greater than 350 and there's a history of diabetes, and they have something else going on, they're either weak, there's coma even, confusion, nausea and vomiting, you can start administering normal saline. We can give 500 cc's of normal saline on the way into the hospital. This is assuming the patient doesn't show any signs of volume overload, which would be, significant pedal edema, rales in the lungs, the usual things that we look for. So starting treatment before we get to the hospital in hyperglycemia is now okay. A reminder also that you can give Zofran as needed for nausea, vomiting. Let's go to the pediatric one. So in 9007, under pediatric diabetic emergencies, it again reminds you about AEIOU tips, and the treatment for hypoglycemia here for blood sugar less than or equal to 60 with a history of diabetes and nausea, vomiting, or weakness. Again, the EMT level can give oral glucose, and at the paramedic level, we're going to give a half a gram per kilogram of dextrose IV up to 12.5 grams. Use your Hantevi app to help you. This is where it's really useful because we can put in the appropriate parameters and we can know exactly how much to give to that particular patient. If the blood glucose remains less than 60, you can repeat as above. Again, if there's no IV and the verification of the diabetes, you can give a half milligram of glucagon IM, or you can go IO as well with the IV dose of dextrose. Glucometer failure is also called out here for suspected hypoglycemia, history of diabetes, confused and lethargic. In these cases, a half a gram per kilogram dextrose can be given, or you can give glucagon. Now, what about the hyperglycemic treatment for kids? Again, similar things here. Blood glucose greater than 350, history of diabetes, confused, some other things going on, maybe nausea, vomiting. Start and administer your IV normal saline at 20 cc's per kilo and transport. This again is assuming no signs of volume overload, which would be unusual in a kid. Adult treatment for seizures, policy 8003. On the BLS side of things, it reminds all of us to keep cognizant of the risk of trauma, especially older folks who fall and have a head injury as a result of their trauma. Don't forget to think about spinal motion restriction in those patients. On the ALS side, there's an added feature to think about, assess and treat the possibility of substance abuse as a cause of the seizures. And then the treatment standard is midazolam. It can be given IV or IN and titrated to seizure control, 0.1 milligrams per kilogram in 2 milligram increments. Remember to push that slow. And if IV or IN is not available, it can be given IM, and the treatment parameters are in the policy. On the pediatric side of things, policy 9008. This policy specifically talks about temperature. We know that the vast majority of pediatric seizures that we transport seems to be febrile seizures. So checking a temperature and starting cooling measures on the way into the hospital is a practice I think a lot of us do, but now it's specifically called out in policy. Don't forget cooling measures for kids who are warm who've had a seizure. If the blood sugar is low, go ahead and treat them as per the policy that we just talked about. And then if you have continuous seizures in kids, IN or IM is preferred. There's actually some large studies, large national studies, that have looked at the use of midazolam IN or IM in kids, and it's very effective. But the IM dose is 0.1 milligrams per kilogram to a max of 4, or the IN dose is 0.2 milligrams per kilogram to a max of 6. Okay, the last two new policies that came out of those decrease in sodium are 8004 and 9011, which are the adult and pediatric versions of suspected overdose. These policies are a little bit different. In the adult side, we're talking mostly about suspected narcotic overdose, so this would be lower respiratory rates, pinpoint pupils. You have a bystander that kind of talks about the fact the person uses narcotics, or you find paraphernalia. In these patients, we want to get to that naloxone sooner than later. 2 milligrams atomized intranasal is the standard here to use for treatment. However, we all know that there's commercially available devices out there that have 4 milligrams. This protocol allows for the use of those commercial devices. So we're going to continue to treat that 2 milligrams intranasal up to a max of 4, or we're going to use that pre-filled device intranasal. If trauma suspected, of course, treat for traumatic injury. Now for the pediatric side of the world, policy 9011, pediatric overdose. This does have some changes in it. In the very introductory part of the protocol, it goes into a discussion about the risk of hypothermia in a pediatric overdose, and that some simple interventions can significantly reduce mortality. When kids overdose, especially on beta blockers, calcium channel blockers, or even narcotics, they can become very hypothermic. And so basically the mantra is warm what is cool, cool what is warm. And so if you have a child here with a narcotic overdose that does feel cool, don't forget about the warming measures. And then if you suspect a narcotic overdose, you've got the symptoms, the pinpoint pupils, again, similar things we had above. Again, this is administering naloxone intranasally. It can be given by first responders, but our route, again, is 0.1 milligrams per kilogram IV-IN, and then titrate to adequate respiratory status, or a maximum of 2 milligrams. Think about trauma in these patients as well and apply SMR when it is appropriate. is a great place to use your Hantevi app if you're going to be giving any medications, fluid boluses. It'll really guide you through that. But then for those suspected beta blocker, calcium channel blocker overdoses, you can use atropine, 0.02 milligrams per kilogram IV or IO with repeat doses after 5 minutes. And you can also use in this category a push dose pressor at 5 to 20 micrograms IV or IO every 2 to 5 minutes. Again, titrating to the patient's blood pressure. Now in the next section, in the tricyclic overdose, again, remember about the use of bicarb. And the big thing I really want to talk about here and emphasize and drive home that probably the first abnormality that you'll see in a tricyclic overdose before anything else changes is heart rate. That's in adult and kids. So if you know that there's been a tricyclic overdose and you're seeing tachycardia, now is the time to start using bicarb. We always think about waiting until the QRS gets wider or something changes in their EKG, you start seeing ectopy. At that point, you're already behind the 8 ball. It's getting to be too late. So when you see tachycardia and tricyclic overdoses, go ahead and start your bicarb. The dose is 1 milliequivalent per kilogram IV or IO, and then watch for changes in effect. Transport quickly. And then in your base presentation, make sure you indicate that you think that this is a tricyclic overdose. The more information you give to the hospital ahead of time, the more efficient the hospitals can be when you arrive. Okay, let's transition over and talk about 8 adult policies that have some minor or some major changes. There's actually one brand new policy called traumatic cardiac arrest. But let's talk about the first one, 8025, which is Burns. They took out a statement under notes, which is cardiac arrest shall go to the closest emergency department. Don't be confused by this. The discussion at MAC and OAC is that a cardiac arrest patient is a cardiac arrest patient. Their condition requires treatment under medical or traumatic cardiac arrest, which is already called out in policy. So follow the corresponding policy if your patient's in cardiac arrest. Speaking of which, the next policy up is 8031, which is non-traumatic cardiac arrest. Not a lot of changes here. Just continue the great work that you do, doing continuous uninterrupted CPR at a rate of 110. We're coordinating our care, changing compressors, pre-charging our monitor, focusing on staying on the chest as long as possible, and staying on scene to work that arrest longer rather than moving the patient, because there's tons of literature out there that talks about the moment you change a patient's GPS position, where they lie, in a medical cardiac arrest or non-traumatic cardiac arrest event, the survivability goes down. We want to try to stay longer if we can. But 8032 is the new policy. It's the new kid on the block. This is traumatic cardiac arrest. So what's different about this policy? Really, there's a couple of things, and the biggest thing that's going to shock a lot of people is we're not going to give epinephrine to traumatic cardiac arrest. We need to search for other causes. Pneumothorax, hemorrhage, something else, airway obstruction, something else that's going to cause this patient to go into cardiac arrest, and we want to try to treat those reversible conditions. So we're going to control external hemorrhage as we normally would. We're going to maintain that high index of suspicion for pneumothorax. We're going to perform bilateral needle thoracostomies, treat for exsanguination, starting those 2 large bore IVs, giving 1 liter of normal saline simultaneously via each IV and IO, using that rapid, that pressure bag for rapid infusion, checking for lungs, and we're going to keep giving those fluids up to 4 liters or the systolic blood pressure gets above 90. And don't forget, if you do get ROSC, this is very important, TXA is called for as long as they've had less than 5 minutes of CPR. So again, the big changes here, if we find a patient in traumatic cardiac arrest, there's an immediate dichotomous decision, work or not. If we're working that patient and they don't meet determination of death criteria, we're transporting early. We're not staying on scene to work that patient. I know it seems odd to be saying that, but we have had a couple of cases in the county in the last couple of years where we stay on scene to work a traumatic cardiac arrest for an extended period of time. And ladies and gentlemen, this is a surgical disease. This has some reversible causes, but it's surgical. We need to get that patient to a surgeon as quick as possible. Transporting early if that decision is made to not determine death, getting on the way to the hospital, and then continuing really good CPR, starting your IVs, giving them fluids. If you get ROSC, giving them TXA, doing the pre-alert. That's what's different. And then don't forget, no epinephrine in traumatic cardiac arrest. Okay, let's jump into 8028, which is environmental emergencies. The major change here is the addition of an envenomation section, which I hinted at the beginning when we talked about alerts, is actually a brand new alert. So if you come across a patient that has a suspected snake bite, you pre-alert a receiving hospital of possible need for antivenom if moderate to severe venomous snake bite is noted. So that leads to the natural question, what is moderate to severe? Well, if you pop down to the next page, it'll define moderate to severe. If you look at mild as pain, tenderness, edema at the bite, but severe is this intense pain and swelling of the entire extremity, often with severe systemic signs and symptoms. And then the moderate is this pain, tenderness, erythema, edema beyond the area adjacent to the bite. So I think the big key factor here is the level of pain and the level of edema. If we have localized pain, no edema or very little edema, that's probably mild. If our pain is escalating and the edema is spreading, that's where it crosses to moderate to severe, and that's where we're going to engage in the pre-alert process to get antivenom ready. Policy 8030, one very near and dear to my heart, which is discomfort and pain of suspected cardiac origin. The pun was intended. There's not a lot of changes here, just a constant reminder about obtaining that single good quality 12 lead in the first 10 minutes after patient contact. So first medical contact is when the first ALS provider has contact with them, and that starts a clock to 10 minutes. We want to obtain a single good quality 12 lead. Make sure that the patient is calm, quiet as possible, and you have no tension on those cables to get the best quality 12 lead. And if that 12 lead says STEMI, we are going to transmit that to the hospital. We're going to call an alert. We're going to give aspirin. We're not going to give nitroglycerin. We're going to treat their pain a different way through the pain policy. And also in this section, the nitroglycerin contraindications are actually called out as a section all to their own. All right, 8042, childbirth. So the big additions here is a section discussing midwives. And it identifies and defines certified nurse midwives, certified professional midwives. We are seeing a lot more families choose the midwife decision, and you might have an event where you're going on care of a patient that has a midwife present. What do you do there? Who's in charge? That's what this policy helps call out. And so midwives can assume primary responsibility for the delivery of the infant and managing postpartum hemorrhage and other birth tract complications. but the paramedics are going to assume the responsibility for the ABCs, airway management, fluid management, seizure control of both the mom and of the newborn. Policy 8065, which is hemorrhage. In this policy, just some minor changes to notice, and that is the fact that there's been a couple additions to the approved tourniquet devices. And then if you pop down to the ALS section, you'll notice under the TXA inclusion criteria, a very important "and" has been put in there. Blunt or penetrating traumatic injury with signs and symptoms of hemorrhagic shock and a systolic blood pressure less than 90. Other than that, the policy remains fairly unchanged. And finally, for the 8000 series, 8066, pain management. The major change here is a departure. If you remember, when we choose either to give ketamine or to give fentanyl, we had to choose one path, and there was no mixing across paths. Well, in the new policy under pain management, you can cross over paths as well. It says do not administer opiates and ketamine to the same patient unless approved by the base hospital. So the complete exclusion of giving both of these to the same patient is now gone, but if you choose to cross over and give ketamine and fentanyl to the same patient, it does require a base hospital order. 9021, jumping back to the pediatric side of the house, this will bring up the rear to be the last policy we talk about, which is pediatric behavioral crisis restraint. This policy goes into a lot of details about law enforcement, what to do if law enforcement doesn't arrive, how to engage with your patient, and things to keep yourself safe and also to keep yourself from getting in trouble. So let's jump into some of those details. So requesting law enforcement, you should request law enforcement assistance if it's needed. And if they don't show up, it's important to document that as well. If law enforcement does not show up, fall back to a safe distance if the scene is unsafe. Notify a supervisor to respond, and even notify the base hospital of your situation. If the scene is safe, attempt verbal de-escalation first, and if for some reason restraint is necessary, all of the following apply. Assure enough personnel are present on scene to accomplish what you're trying to get done. That includes police, assuming the patient is abusive or violent. Next, replace handcuffs with leather or cloth restraints once on the gurney, unless the patient is being legally detained, in which case a police officer must accompany the patient in the ambulance. So they have to be physically with you in the ambulance. And just a reminder, everybody, that sitting, supine, Fowler, and semi-Fowler positions are the approved positions to transport a patient in. And very importantly, have a cardiac monitor in place and SpO2 in place as well, with every 5-minute vitals and mental status exams being taken. On the ALS side of the house, midazolam, you can use midazolam if the patient is 12 years or older only, with a dose of 0.1 milligrams per kilogram given IV in 1 milligram increments, IN or IM, with a total max dose of 3 milligrams. Notify hospital personnel if the patient elopes in your care. That's happened. Don't think with kids this year, but definitely with adults. We've had a psychiatric patient elope while we were transporting into the emergency department. Notify the hospital staff if that happens. Be wary that there is a possibility of domestic or physical abuse in these kids who are experiencing psychiatric emergencies. And finally, at the very bottom, you'll notice a couple of notes. If there is a suspicion of alcohol intoxication, avoid using benzodiazepines like midazolam. Consider all possible medical and traumatic causes for behavioral crisis like hypoglycemia. Don't forget to keep your perspective wide, keep your differential wide. Don't get too narrow too fast and become fixated on one particular thing or diagnosis you think is going on with the patient. Okay, folks, that wraps it up. I hope that was helpful to you. We covered 21 policies that have minor or major changes. We've covered 7 brand new policies, and we did not cover 41 policies that really didn't have any changes or didn't really apply to the field. I want to thank my host, Casumnas Fire, for allowing me to shoot this in their EMS training division. And I also want to thank again Julie Carrington for her help in getting a lot of this information together. Look for the CE test, get your CE, and happy EMS week if you're seeing this during EMS week, and if not and I didn't get a chance to see you, we appreciate everything you do. We know that your job is tough. We know that you do great work. We know you make a difference in patients' lives, and it's just a huge honor to be able to work with you. We'll see you on the next edition of 5 Minutes or Less of EMS.